Good afternoon, everybody, and welcome to another injury series for the lower limb. I hope everybody is doing well today. I hope you have a fabulous week, and I hope you've had a good day so far as well. My name's Caitlin, and I'm going to be looking after you for the next half an hour, and we're going to be going through some common hip pathologies and treatments today. So with the lower limb, we have already covered the ankle and the foot and the knee. So today we've come up the body and we're finishing on the hip. So if anybody does have any questions during the program, then please do pop those in the Q&A panel. I will keep checking. I will unless there's quite a few common questions, I will tend to leave those more towards the end to answer, but I will keep an eye on the box just in case. So the first bit of this session then, if you haven't joined us before, it is a little bit of theory. So we found that quite a few people are actually really interested in knowing a little bit more about the body. So I've put a little bit of a presentation together to go through what the hip involves and the most important structures around it. And once we've kind of discussed a few of the most common pathologies, we'll then have a little bit of an exercise session. So it'll only be about 10 minutes for the exercises. It's not very long. And it'll be very much specific for the hip. If you do have any conditions, then do be aware when we do the exercises that it might cause some symptom aggravation, but I will get to that bit just when we get there. Okay, so our hip pathologies then, it is quite a large and stable joint. It's one of the most stable joints in the body. And obviously it has to be because we have to weight bear through that joint. Okay, obviously we have two because we have two hips. So the most common pathologies that we see as medical professionals and physical therapists is osteoarthritis, muscle strains, hip fractures, bursitis, labral tears and tibial band syndromes, that's your ITB. I didn't mention before, my role is a rehabilitation therapist. So basically I get people coming to me with all sorts of different injuries or pathologies, and I rehab them through exercise. So I am very biased towards exercise and the benefits of it, but research has also kind of backs me up there because it is shown to be one of the most effective treatments post-surgery, prior and post-surgery. So today we're going to focus on the top three pathologies. So we've got previously osteoarthritis. So I took on board feedback from last time we did this, wanting to focus on just a specific type of arthritis. So this is the most common. Then we're going to look at muscle strains and hip fractures as well. Okay, the other three we can cover in later sessions. Okay, the anatomy of the hip, it is very, very complicated. So I've split this into two slides. So we're going to cover the muscles first. Obviously, you can see from the picture here, it is very, very complicated. The picture on the left is an anterior view and the picture on the right is a posterior view. And they're only superficial muscles. So your deeper ones we won't be able to see. So we'll start off with, we've got several groups. We've got 4 groups of muscles that make up the hip. And we're going to start off with the adductor group. Okay, so we've got the adductor brevis, adductor longus, adductor magnus, pectineus and gracilis. Some of them are Latin names, and I do have dyslexia, so I do struggle to pronounce some of the Latin names. So I do apologise if they don't particularly make sense. I do apologise. So these group of muscles, they are responsible for moving the femur. So that's your big thigh bone. It's responsible for moving that to the midline from an abducted position. Okay, best way to remember abduction and adduction. Abduct, if you take your leg out to the side, imagine it's being abducted by aliens. It's going up. Adduct is coming back down. Okay. These are deep-lying adductor muscles that originate from the pubis and attach to the length of the femur. And each muscle has its very own role and specific movement pattern from extension to rotation. Now, we would be here all day if I went through the exact movements and the orientation of all of the muscles. So we will maybe cover that another time if anybody is interested. We're going to go on to the lateral group, so the lateral rotator group of muscles now. So we have the externus and anterior abrators, the piriformis, the superior and inferior gymnal. Again, not sure if I am pronouncing that correctly. Now you can see here I've only highlighted the piriformis because the other ones They are due to their location because they lie much deeper, but they are located kind of around where the piriformis is, so they lay just underneath. This group of muscles are deeply located and act to laterally rotate the thigh at the hip, and these muscles originate from the pelvis and attach to the femur as well. Moving on to the gluteal group, we've probably heard of these muscles quite a bit. So we've got our glute maximus, glute medius, glute minimus, and we've got another one as well, which is our tensor fascia latae. I'm not sure, again, not sure if I'm saying that 100% correct. They are very complicated names. Okay, the gluteal group of muscles, they are superficially located, and their main role is to abduct and to extend the thigh at the hip. The glute medius and minimus are located underneath the glute max, and with the minimus being the smallest and the deepest of the three. And then finally, we have our iliopsoas group. So we've got our iliac and our psoas major. So these ones just here. These muscles are located deep in the back near the midline, immediately adjacent to the spine. So they originate from the base of the spine and attach to the femur and aid flexion at the hip. So like I said, there's so much that goes on within the hip. It's very, very complicated joint. Now, I said I split it into two because we also have lots of important ligaments around there. So it was too difficult to put all of it in one picture and find a picture that has all of them as well. So when we look at the hip, the primary function of the hip joint is to provide dynamic support and the weight of the body in the trunk while facilitating force and load transmission from the axial skeleton to the lower extremities, allowing mobility. So when we look at the ligaments, so the capsular ligaments include, again, complicated names, our iliofemoral ligament. So that's also known as the Y ligament, and that is the strongest ligament in the body. It lies on the anterior aspect of the hip, and it prevents hyperextension. We've got our pubofemoral ligament, which lies anteroferially. It prevents excess abduction and extension. All these Latin words getting my tongue twisted. And we've got our ischiofemoral ligaments, and this is the weakest of the three ligaments and consists of a triangular band of fibres that form the posterior hip joint capsule. It attaches to the ischium to behind the acetibulum, and it attaches to the base of the greater trochanter, and that prevents excessive extension. We also have the ligamentum teres. So this is the head located at the head of the femur. So we've got located in the intracapsular and attaches to the apex of the cotrod notch and to the femoral head. Again, very complicated to understand, but don't worry, it's just to give you a basic idea of how much actually goes on in these areas. Injuries to the ligament teres can occur in dislocations, which can cause lesions and lesions of the artery around there, and can result in osteocorosis of the femoral head as well. So hopefully I haven't lost anyone. I'm going to quickly check the questions. Oh, I've got one here. Oh, somebody just mentioning about the ankle and the knee. Yeah, of course, I will come on to that later on in the session just to discuss that a bit further. So just hang fire, I'll talk about it later. Okay, I mentioned about osteoarthritis, okay? So this is one of the most common pathologies that we'll see, and it can occur at any age. So we know that the hip is one of the largest joints in the body. It's a ball and socket type of joint. And the socket is formed by an acetibulum, which is part of the large pelvis bone. The ball is the femoral head, which is the upper end of the femur, so that thigh bone. So where it's if you look on the picture, hopefully you can see my mouse, but just here, this is your femoral head. Okay. So in osteoarthritis, the cartilage in the hip joint gradually wears away over time, and as it wears away, it becomes frayed and quite rough, and the protective joint space between the bones decrease. This can result in the bone rubbing on bone. So to make up for the lost cartilage, the damaged bones might start to grow outwards and form those bony spurs, so they're their osteophytes. Osteoarthritis develops slowly and the pain can worsen over time. And it has no specific cause, but there are certainly factors that can make you more susceptible and more likely to develop the disease. So increase in age, that is one of the most common factors. Family history of osteoarthritis, so whether it's a common factor in your DNA, you might be more susceptible to the degeneration. Previous injury to the hip joint, so we know that if you've had any sort of trauma to a joint, it does increase that risk. Obesity, and improper formation of the hip joint as well. So things like hip dysplasia could potentially cause an increased risk of getting osteoarthritis. You can still develop osteoarthritis even if you don't have any of the risk factors mentioned above. So the most common symptom of hip osteoarthritis is pain, and it's common all over the body with osteoarthritis as well. It develops slowly and can worsen over time, and although the sudden onset is also possible. So pain and stiffness might be worse in the morning or after sitting or resting for quite a while, and over time painful symptoms might occur more frequently and during the night as well, or during rest. So if you do feel like you have osteoarthritis or you are slightly concerned with your movement and pain, it's a good idea to have a chat to your doctor and just have a discussion about your symptoms, medical history, and they'll be able to conduct a physical examination. Again, it doesn't have to be your doctor. You can come to someone like myself who will be able to go through similar things. It might be that a diagnostic test is needed, such as an X-ray, just to be able to kind of determine what the hip is looking like this picture on the screen. And then your non-surgical treatments are things like involving lifestyle change, physical therapy, potentially an assistive device such as a walking aid or medication. Sometimes, if the symptoms haven't reduced with non-surgical treatments, a full replacement of the hip might be required. So things like hip resurfacing, where the damaged bone and cartilage are replaced and replaced with a metal shell, or an ostomy, and that's where the cutting of the femur or the socket is cut to be realigned to release pressure. So there's a lot that can go on with osteoarthritis in the hip. Muscle strains, a really, really common one actually, and a lot of people will just pass it off and just try and deal with it. Basically, with our muscle strains, it mainly affects our hip flexors. That's our iliac and apicius major and the rec fem muscles. Now, with that, our main work is to bring your knee up towards your chest and to bend at the waist. Symptoms associating with a hip flexor strain can range from mild to severe, and it can impact your mobility. If you don't rest or seek treatment, your hip flexor strain can become worse. But there are there are many at-home activities and remedies that you can do to reduce this hip flexor strain and symptoms. So the main pain, where it is located, is mainly at the front of the hip. But there are several other symptoms that can be associated with the condition. So pain that seems to come on quite suddenly, increased pain when you lift your thigh towards your chest, pain when you're stretching your hip muscles, muscle spasms at the top of your hip or thigh. Tenderness is really, can be quite a big one. Swelling and bruising at the top of your hip or thigh is also another one to look out for. And it occurs when you use your hip flexors, muscles and tendons a bit too much. It's basically an overuse injury. And as a result of that, the muscles and the tendons become inflamed, sore and painful. So there's some people that are more likely to experience this than others. So things like people like cyclists, dancers, martial artists or gymnasts, kickers in football, American football players, and sometimes some step aerobic participants as well. Basically a lot of hip movements. Athletes who are running or jumping quite a lot while performing high knee kicks, they're also greater risk at having a hip flexor strain. It can happen in older adults as well. Again, if you've got degenerative conditions, muscles can be weaker and that can cause a strain. They are graded 1 to 3, depending on the severity of the tear. So 1 is just a minor tear, only a few fibres are damaged. Number 2 is a significant number of muscle fibers that are damaged to moderate loss of hip flexion. And grade 3 is a complete rupture or torn, and usually you can't walk without a limp. So the best form of treatment for this kind of strain is just to firstly rest. It's the most important thing to do. And then look at kind of changing activities that you would do daily, and trying to avoid stretching the muscle for the time being. So icing it to reduce the swelling, also using heat packs to reduce tightness, and over-the-counter medication as well. Again, physical therapy is often recommended to reduce the tension, build strength, and reduce the risk of injury reoccurring. And in very, very rare cases, sometimes surgery might be required, but it is a very small chance. And finally, hip fractures. It is such a common injury to have, and it is more common in older adults compared to younger people. But again, it depends on medical conditions. Hip fractures usually occur in the older people, and it is usually from a minor fall, particularly in people who've got osteoporosis. So that's a degeneration of the bone. Usually when moving the affected leg, standing or walking, that causes substantial pain. It can be diagnosed with x-rays and sometimes other imaging testing, and sometimes surgery is done to repair the hip and sometimes even replace the joint. So we've got 2 main types. There are other types of hip fractures, but these are our most common. So our femoral neck, also known as a Knopf fracture, so that's a neck of femur fracture. And that is where the fracture occurs of the neck of the thigh bone. So these fractures are particularly problematic because they fracture and often disturbs the blood supply to the head of the bone. Without a good blood supply, the bone cannot grow back together, and it may eventually collapse and die. Okay, so that's the osteocoronosis. Severe, painful arthritis may also develop. We also have our the femoral neck hip fractures may be repaired by inserting metal pins through the neck and into the thigh bone. Going on to oh, sorry, I've just lost where. Sorry about that. So the fracture rarely, so the intratrochanter hip fracture, that usually goes through the large bumps just below the neck. This fracture rarely interrupts the blood supply to the head of the femur. The broken surface of the bone may bleed, but not usually cause enough serious problems. These fractures usually result from a direct blow or a fall. And you've got your with these hip fractures, sometimes when the hip is broken, pain seems to come from the knee, so it's and instead of the hip, and it feels that way because the knee and the hip share a same nerve pathway. So this is called referred pain. You might have heard of that before. If the hip fracture forces people to stay in bed, they are more at increase of risking other serious problems due to the bed rest. So things like pressure sores, blood clots that might lead to a pulmonary embolism, mental confusion, and even pneumonia. But the main one is loss of muscle and decrease in physical fitness. So that's called deconditioning. As with most musculoskeletal pathologies, physical therapy is advised to regain the strength and mobility of the muscles surrounding the joint and reducing the risk of re-injuring the area. So, exercises. This is why we're here. This is what we do. This is what I do as a job. And these are the main exercises that we do for hips. Obviously, this is only just a small handful, and there are many, many more. But we've got ROM, so that represents active range of motion. So we'd look at your active range of motion hip extensions, active knee flexion, mini knee bends, sit to stand, and seated hamstring stretch. So we're going to have a go at some of those today. Now, obviously, it depends on hip pathology, which one you have, if you have any, if you've had surgery, and whereabouts you are in your recovery as well. So this is a generic exercises for the hip. It's not specific to the 1 or 2 of the conditions that we've done today. Some of these exercises I have actually taken from my granddad's rehabilitation program, as he actually did fracture his neck of femur, so that Noth fracture. He fractured that a year ago, and I got him to send me some of his exercises that he did. And just so you all know, he's up and walking absolutely fine now. A year later, we basically have to make him sit down. So we're going to do these exercises then. So all you're going to need is a chair. Make sure you're nice and sturdy, and I will just take 2 or so minutes just to get set up, and then we can have a go at some of these exercises. Okay, lovely. Hopefully everybody has their chair ready and is ready to do some exercises. So I'll just get my timer there. Lovely. Okay, so we're going to start off with a little bit of a warm-up. Obviously, it's only a few little exercises we're going to do, but if we do have any pathologies, it is always really important to do a bit of a warm-up. So we're just going to start with some marching on the spot, which is obviously really good for our hips. So like I say, you're not going to need any equipment, just your chair, that's all. And if anybody does have any experiences that they're happy for me to share within the group, please do write those in the Q&A panel. It might be that you've tried some different exercises that are those that we're going to do today, or any experiences that you might have had in the past with any of the injuries. So someone mentioned in the comment box, just while we're marching, I'll address this, and they mentioned about the knee and the ankle classes. So what's going to happen now is, obviously we've got to our hip, that is the last area for our lower limb. What's going to happen now, when we come back in 2 weeks time, I'll go back to the foot and we'll do slightly different pathologies from what we did last time. So if you were here before, it should be slightly different. And if you didn't attend before, then please do join us. So that'll be in 2 weeks time. Next week is another upper limb class. Okay, we're going to bring those knees a bit higher, obviously if your hips allow. So only a very small warm up. Lovely. We're just going to do marching in this warm up today. We don't need to do too much. Okay, slowing that down. Lovely. So we won't be really, really warm, but we'll still got the blood going to the hips a little bit more. So grab your chair and we want to stand behind it. Hopefully yours is a bit more sturdy than mine. But we're going to do our active range of motion hip extension. Okay, so standing tall, you're going to take, it would be your affected leg, but if you want to try on both, that is fine. You're going to take the leg and you're going to bring it back as far as you can and then bring it back like so. Now what we most commonly see is people will do this. That movement is now coming from the spine, not the hip. So you really want to isolate that area, hold on tight, draw it back and up. If you can't manage that and you are really limited in that movement, you're going to tap back where you can and bring it back. So what I would like you to do is just alternate sides each time. Okay, so have a go at that for me. And what we're doing here is we're trying to work these glute muscles. Okay, so they're the muscles that live in your bottom. trying to get those working, getting the extension, building that strength. I'm not going to go into the specifics of each movement for each exercise, otherwise again we'd be here all day. So try and keep the leg directly behind you. We don't want it coming out to the side, that's a different movement. We're only doing extension for this one. Let's see if there's a comment coming up there. No, that's fine. Okay. We'll do one more on each side. Good. Okay, so usually with these exercises, you probably have maybe 2 sets and you would do each set 10 times. So it'd be 1, 2, 3, so on for 10 times, rest and then do it again. Next one, we're going to be doing active knee flexion. So this gets the hamstrings working a bit more and we need to keep the hips nice and straight. Hamstrings join up here. So we're going to bring the foot up and down. Okay. Now all the weight now is going to go into one side, so you might feel it more. We're still going to alternate like we did before on the last one, raising the heel to the bum. Okay, getting those hamstrings squeezed as we raise the leg up and down. Good, keep that going. Lovely. Okay, one more each side. Okay, still holding on to the back of the chair. We're going to do our little knee bends. So we're coming down and up. We're building that strength up into the quads, getting all those muscles working here and the ones that join up into the hip. Coming down and up. Now, a lot of people will see, we'll do this. That's dropping the chest down. We're not getting the movement of the hip. Small, not quite a squat. It's just a little knee bend. Good, so we're just going to do a few more of these. And again with the hip, because the lower extremities, they're all joined together, obviously all joints are joined together, but the lower limb is really, really strong. So if there's any sort of effect in the hip, that can affect the knee. Anything in the knee can affect the ankle and vice versa. So doing this exercise obviously gets our knee flexion extension, getting the movement in the hip. We're also getting flexion extension, well, more flexion in the ankle as well. So if you've got reduced movement, it's a really good exercise to do. Okay, still holding on to the back of the chair. We're now going to do that hip abduction, okay? Remember, abducted by aliens, the leg or the extremity goes up. So abduct, up, adduct, down, okay? We're going to abduct the leg. We're going to raise it up, adduct down, up, down, okay? If that is too difficult, just like with the extension, you can tap and come back in. Okay, so have a go at both sides for me. I'm going to spin my chair in front so you can see my legs coming out to the side. That's probably not going to be helpful at all, actually. So usually we just do one side and then do the other. But we'll do it like this today. Good, so you should really feel it pinching in those hips. And depending on your mobility, you might be able to get your leg higher than mine. You might be able to not get your leg as high as yours. Whatever your mobility, that's fine. It's progression that you can work on. You know, ideally I'd like to get my leg a bit higher. Something I've just got to practice. Okay, one more each side. Lovely. Okay, grabbing your chair again. It's a really chair-friendly exercise group, this.
Knees to the back of the chair. Now, hopefully you don't have a spinny chair like mine. Please make sure you've got a sturdy one. That's all I have in the house. So you're going to come and sit down on the chair. I'm going to stand back up again. Nice and simple. Sit to stands are your best friend in rehab. If it's a knee issue, if it's an ankle issue, if it's hip, if it's a back, these are the best exercise because it's getting quite a lot of the joints involved. Upper body, not so much. Oh, I've got a squeaky chair. If you're really struggling, you can come down as much as you can, use your hands for support to lower yourself down, and use a little bit of a push to get back up again. But we really want you to try and do it without your hands. Okay, we'll do a couple more and then we have one exercise left. It might not be exactly what was on the presentation, but still all relevant. Okay, we'll do one more. Okay, come down to sitting for me. So we're going to sit a little bit more on the chair now. I'm going to come back. So we're going to do some hamstring stretch. So one foot in front, make sure you don't slide off your chair, make sure you're nice and sturdy on it. And we're just going to lean forwards until you feel that stretch in your hamstring. So you might get to here and you might feel it. You might get all the way down here and feel it. So you're just going to hold it in that position, make sure you're not sliding off your chair, so hold it for support. You're going to hold this, usually we'd hold it for about 30 seconds. But I want you to come up and I want you to move to the other side. So we've got a good feel on both legs. And this helps to stretch the hamstrings and the nerve roots as well. So we have our sciatic nerve that runs right down from our pelvis down through our hamstring, down our leg. This is a really nice stretch for those. And coming up. Lovely. Okay, let me come to you guys. Bring my chair in. So I hope everybody has found that beneficial today. Obviously, some of the exercises I may have missed off, I may have added different ones in, but they are all very relevant to hip pathologies and strengthening the areas as well. You can do some of those if you have a knee pathology, but like I say, these ones are very specific to the hip. Now, if anybody does have any questions regarding today's session or anything about the lower limb classes, then please do pop that in the Q&A panel. Like I said, if anybody has any experiences or anything that they're happy for me to share with the group, again, please do pop that in there as well. And if you've got any feedback for us, please do leave that in the feedback form in the publish tab. It is still a very new class, so any feedback that you guys are giving me, I'm writing it all down and implementing it in my sessions. So if you want to see something more of one thing and less of something else, let me know and I'll try and merge everyone's feedback all into one. I really do appreciate it and I just want you to all know that. So I hope you've enjoyed today's session. I will turn my camera and microphone off now and put the end slide on, but I'll stick around to answer any questions that you might have. Thank you so much for having me today and I'll see you all very soon. So I've not received any further comments or questions there, so I'm going to end the event. Thank you again, everyone, so much for your feedback. It really is greatly appreciated, and I'm glad that you're enjoying these sessions. So next time, it'll be in 2 weeks' time, I believe. We will be coming back down to the foot and the ankle for some more of those pathologies. So if you want to join me, then I will see you there. I hope you all have a fabulous weekend.